and welcome to today's program entitled SSO2 Therapy in STEMI to Reduce Infarct Size, a conversation with global thought leaders. My name is Dan Burkhoff, and I'm from the Cardiovascular Research Foundation, and it's a pleasure to be joined today by three world-renowned clinician innovators. First, from Hanover Medical School, Dr. Andreas Schaefer.
Yes.
Next, Dr. Richard Schatz from Scripps Heart, Lung, and Vascular Center. Hello, Richard. And finally, Dr. Steve Yakubov from Ohio Health Research Institute. Hi, Steve.
Hey, Dan.
Thanks all for joining us today. So today's program entails a combination of presentations and discussions about the trends in STEMI outcomes, an overview of TherOx SSO2 therapy, and real-world results and experiences with SSO2 therapy. We'll have live Q&A following the presentation, so please remember to submit your questions in the Q&A box below, and we'll try to answer as many questions as possible during the discussion towards the end of the webinar. As a reminder, this session is hosted by Radcliffe Cardiology and is supported by ZOLL. Here are a few of our disclosures. Here you see data related to 1-year mortality, 2-year mortality, and 2-year heart failure hospitalization trends since between 2005 and 2018. What we can see is over this time period, for patients presenting with anterior STEMI treated with PCI, that 1-year mortalities have been relatively stagnant at around 10%. 2-year mortalities have increased a bit from 11 to about 15%. And 2-year rates of heart failure hospitalizations have been pretty steady at 20%. So while we have reasonably good outcomes in terms of mortality, there's still, and also heart failure hospitalizations, there still is a long way to go. So to put this into perspective and to also give us a little bit more of the history of how we've got to where we are, I'd like to ask Dr. Schatz to give a few thoughts.
Thanks, Dan. Well, as you can see from this slide, this is for the benefit of the younger doctors who might be watching today. In 1973, I saw my first STEMI, and it was really a shock to me because of the treatment at the time was basically nothing. On the left, you see that we had a very high mortality, 15 to 25% mortality. These are non-shock patients. And the treatment was basically nothing. You would keep the patient in the hospital for 4 to 8 weeks at strict bed rest, sometimes longer. The only medicines you were allowed to give were Lasix, oxygen, digoxin, aminophylline, and morphine if they were in heart failure. Angiography was absolutely forbidden. And likewise, nitroglycerin was forbidden for fear of a Steele-type syndrome. If you fast forward, one of the great accomplishments in medicine, I think, has been the treatment of STEMI, for the simple reason that the combination of medications like lytics and balloon angioplasty, then bare metal stents, and then drug-coated stents, we've been able to reduce the non-shock mortality to as low as 3 to 5% in the first in hospital or the first 30 days, which is really a striking improvement. I think more impressive is how we do it through radial access and other measures. We can predict pretty much a 1 to 2 day stay in the hospital in the absence of shock. We have lots and lots of medications that we can give. Each has its own role. Bottom line is to reduce infarct size and improve clinical outcomes. Of course, we take patients to the lab immediately, and everyone gets a stent nowadays. So a lot has changed, but this focus has been on epicardial flow. And the real frontier now is, why is it that not all patients get better? Some look good epicardial wise, the stent looks good. There's reasonable flow, but some patients just don't get better. So why is that? One area that has changed quite a bit, there used to be about an 80% mortality for the shock patients. That we've hit a wall at about 40 to 50%, as you can see from this study here. This is the culprit shock trial. And you can see from the landmark analysis that most of the events are early on, 30 days or so. And then there's this plateau effect. It makes one wonder what these larger infarcts, what's going on at the cellular or microvasculature level to explain why we're not getting much better in this area. and there hasn't been a lot of success in this particular area. This slide is very similar to Dan's, and it shows that with or without PCI over time, there's this gradual decay in clinical benefit when you look at heart failure. And this might be the real frontier because this is a large event. If we're looking at trying to change the mortality of these patients already at 3%, it's going to be a little hard to get better than that or to show it without gigantic trials. But heart failure and rehospitalization turns out to be a very good target for us. And this is probably where we will be looking in the future. So what's going on at the cellular level? Turns out there's a lot going on. We've known for years about reperfusion injury. The question is it reversible or is it irreversible? On the left, you can see the reversible causes, and on the right, you can see the irreversible causes. And what we don't want to do is we don't want to wait too long to treat these patients because there's a lot going on at that cellular level. We don't want to get to that apoptosis stage where the cellular mechanics have been destroyed and they're not reversible. We want to be more here on the left side of the chart. And in order to understand that, you have to sort of see what's going on. And there's a lot going on, not just in the flow dynamics, but also at the cellular level. So we need something that's going to improve the intervention at every point along this cascade, from epicardial flow all the way down to the microvasculature, and possibly blunt this inflammatory reaction that we're seeing at the cellular level with free radicals and peroxidases that develop that can cause cell death. So we want to shift this curve a little bit more towards the reversible side than the irreversible side. And we don't really have a lot for that until now. And this slide is to remind me to talk about the definition of MVO or microvascular obstruction. Turns out that the actual definition is a little bit muddied through the waters based upon the technology as it evolves, but MRI might be the very best way to look at this. With gadolinium, and you can see that there are very distinguished hallmarks of MVO that's picked up by MRI, probably the most sensitive way to look at this. And that's important because for 20 years, all we've talked about was no reflow or blush scores or slow flow in the distal vasculature without real quantification. But now we can quantify it, and that becomes important because now we have some very good studies that have looked at this critically. And this is a really important trial for a bunch of reasons. It used modern technology to define MVO. You can see there's a meta-analysis of some 7 trials with about 1,700 patients. And the real interesting number is right here. If you were to ask the average cardiologist, who's been doing STEMI intervention for 20 or 30 years, and you ask them what is the MVO rate, they'd probably say 10 or 20%. The real number is probably higher, and this is the highest number I've seen in the literature. Almost 60% of patients have some measurable microvascular obstruction by MRI, which probably is the most sensitive marker for it. So that becomes our target, and this is probably the way we should be looking at this. So until we can improve that number, we're probably not going to have a very big impact on hospitalizations and heart failure. The study showed also that MVO was an independent predictor of all-cause mortality, and there was a graded response, almost linear. The worse the MVO, the higher the mortality. And more importantly, the next line, you'll see patients who had real demonstrable MVO had much larger infarcts. And we know for sure that the bigger the infarct, the worse the patient does. And that's, no matter what study you look at, you're going to see the same result. The bigger the infarcts, either measured by infarct size or ejection fraction, the worse they do. And in this particular study, here was the gradient effect. The better the MVO, the lower the mortality, the higher the MVO here. This tercile here, you can see mortality was much higher. So this is very consistent. I think it's reassuring that we now have a very good way to look at this non-invasively with MRI. And I just picked a couple of other studies to remind us all that LV function does matter. The bigger the infarct, the worse the patient does. This is a big meta-analysis of several trials from the AP literature. And again, we see this gradient effect. The top line is when there is no improvement. Here you see in the top line here, when there's no improvement in ejection fraction after the first STEMI, you can see the mortality is very high. This is cardiac arrest, non-cardiac arrest. In every category, there's a gradient. So the smaller the infarct, first infarct, the better the patient does, the bigger the worse. No surprise. That's what all the shock trials tell us as well. And in this most important meta-analysis from Greg Stone, you see the exact same thing. Huge study of thousands of patients, and you can see the similar gradient. So infarct size really matters. and it's probably related to MVO. Anything we can do to improve MVO and improve LV function will slide us along this gradient to better outcomes for both mortality and for heart failure and hospitalization. So here's a fairly typical example. This is from my lab. We did a handful of studies during the IC Hot trial. I think this was probably one of the more impressive patients, but they all but one had this kind of result. You can see a classic tombstone anterior LAD. This is a de novo virgin LAD. Patient was 5 hours into his STEMI. And when he came to us, he didn't have a lot of collateral. So we expected a big infarct. And you can see that there is a stump right here, reperfused. And even though his flow was actually pretty good, he looked like he had TIMI 2 to 3 flow. But at the time of the STEMI, we did an LV-gram, and you can see this very substantial high anterior apical inferior wraparound LAD type infarct. So while you would expect some improvement just spontaneously, you see about a 3 or 4% increase in ejection fraction with just epicardial reperfusion like we normally do. But it's pretty rare to actually see a ventricle return to normal after 5 hours of infarct and this amount of myocardium at risk. So a couple of days later, I think it was 3 days later, we see the EKG here, classic evolutionary anterior infarct, a few waves there already. So one would expect to see some damage. If there was improvement, I would not expect too much. But this patient did get SSO2. And you can see, much to our surprise, just 30 days later, that big anterior apical defect is now gone. His ejection fraction was 60%. This was a pretty drastic surprise result because of the amount of damage that we saw. And when we look at all of our patients that we did in the study, we can see on the left baseline EFs, and you can see that they all got better pretty quickly. And we had some 4-year follow-up even, and it was sustained. All these patients did clinically well. The black line is the mean. And if you go back in the last 20 years and look at ejection fractions in every anterior STEMI trial that's been out there, there's about 100 trials out there. Their baseline ejection fraction runs about 40%. And at 30 days, with just epicardial intervention, you do see improvement in ejection fraction up to about 45%. Every study is very consistent. So we went from about roughly 30 to 35% up to about 60%. Small numbers, of course, but it was pretty striking in these 4 patients. We had a 5th patient that we did, but that patient had a previous anterior infarct and we didn't know about it until it was too late. We already treated him. So pretty striking results. We were very satisfied with this. And you'll see from the other data, all these got SSO2, obviously. And we were very surprised at this, and it's very consistent with what other investigators have found as well.
Thank you, Richard. That was really informative. Let's dive a little bit deeper into the SSO2 therapy in STEMI. You see here on the left, the TherOx device that delivers SSO2, and we're going to be hearing more about that from Dr. Yakubov in just a second. And in the middle, we see here the issue that we're dealing with, microvascular obstruction. And what you can see is these capillaries, the endothelial cells are swollen. There are blebs. There's all sorts of, there's potentially compression of the capillaries by swollen myocytes. And this creates a situation where red blood cells are rouleauing and not able to really get through to the capillaries to perfuse the myocardium. And this is really part of the no reflow phenomenon, a very important component, and really defines what we're talking about when we're talking about at a cellular level, let's say the microvascular obstruction. So what's the concept of the SSO2 therapy is that supersaturated oxygen infused into the blood, that oxygen is able to diffuse out of the capillaries into the myocardium and reach distal locations and actually provide oxygen to those endothelial cells, to the myocytes, and reverse that swelling that you see, and therefore open up the vessels. So this is really open up the capillaries. This is really the concept of what we're dealing with supersaturated oxygen therapy, to put it very simply. And in preclinical studies, what has been shown is that the delivery of SSO2 can markedly reduce the infarct size. So here you see slices of myocardium from a preclinical study. On the left is a control animal that had a proximal LAD occlusion, and the white area here depicts the infarct size. So you see here, it's roughly about 25% or so of the entire myocardium. On the right side is a representative slice from a preclinical model, which received the same proximal LAD occlusion, but also got the SSO2. And of course, on both of these sides, there was reperfusion at 90 minutes. And on the right, you see that there's very little infarct, very small areas that are staining in that pale yellow. So preclinical studies have clearly shown that there's improvement in regional myocardial flow, as well as reductions in infarct size. So Dr. Yakubov, I was hoping now that you'd discuss some of the clinical results that we have about SSO2.
Thanks, Dan. I really appreciate that. And just to tag along with Richard had said, you know, it's so good to have therapies that improve perfusion to patients now. But I agree with him that at least 60% of patients probably have some sort of impairment of flow into the coronary arteries. And finally, supersaturated oxygen can help many of those patients, especially in the LAD distribution. Now, what we've seen through randomized clinical trials is that you can reduce the relative infarct size, even clinically. And here's a demonstration of the Amy Hott 1 and 2 clinical trials showing a combined reduction of about 26.5% in relative infarct size, correlating with a relative mortality difference. So you can translate these reductions in myocardial infarction sizes to a reduction in mortality. The next slide shows that it also changes the left ventricular remodeling that occurs at 30 days. On the left-hand side, you can see that there's an improvement that occurs from baseline in Icy Hot in improving the left ventricular remodeling that we see at 30 days. So not only do we improve perfusion, reduce myocardial infarct size, improve mortality, but also there's a change in the remodeling, and I think all of that affects the overall mortality of these patients. Now I'd like to get on to a case presentation of how we use SSO therapy in the catheterization lab. So our indications are typically patients that have anterior myocardial infarctions and they present within 6 hours. Now there's been a big push to get patients to the lab immediately, as we do at all of our institutions. COVID has changed things a little bit, so patients want to stay at home a little bit earlier. But I'll present to you this case of a 68-year-old man with a anterior myocardial infarction presenting 4 hours to the cath lab, and his blood pressure is a little soft. Blood pressure is 96/60, his heart rate was 96. And here on the left, you can see the angiogram showing a reduction in his left ventricular wall motion. His right coronary artery had severe stenosis or moderately severe stenosis in the proximal vessel, but that was not the culprit vessel. The culprit vessel was truly the LAD. And here's a series of injections. On the left, you can see that the LAD is totally occluded. There's a stump at the ostium of the LAD. The vessel was then wired. The diagonal branch was protected. Balloon angioplasty and stenting were performed of the LAD with protection of that diagonal branch. There are 2 stents that were placed in the LAD. And there still is not ideal flow that you could see with the wire in the middle segment, and then on the right-hand screen with the wire out. So medications were given into the artery, nipride, adenosine, et cetera, trying to improve capillary filling or capillary refill of this coronary artery. Stents were appropriately sized, confirmed by IVUS. And so what do you do at this point in time? This is a classic case of what we would use SSO therapy. So the patient presents within 6 hours, the LAD is promptly opened. We still don't have ideal flow, even with additional medications. His blood pressure improved with opening the LAD, but we still have an anterior wall defect. So how do we get the most optimal benefit to the patient? So we would start SSO therapy at this point in time. Again, here's an image showing that the flow in the vessel is not ideal. So here's our final angiogram with some spasm in the mid-segment of the vessel in between the two stents before SSO2. And then after an hour of supersaturated oxygen, you can see that the flow is much better in the vessel. Now, I'm not saying that that happens immediately, and there's many factors that can cause improvement in flow, but I think overall, if we can demonstrate this type of improvement, we'll translate that into a decrease in our infarct size. His echocardiogram at one day is on the left, and his 1 month echo was interpreted as improvement in his left ventricular function. So the mechanism of how we actually do this in the catheterization lab is many of our cases are done through radial access at this point in time, but to infuse supersaturated oxygen, you need a second arterial access. So what we'll often do is, after having performed our procedure through the radial access, is keep that in place and then put a 5 French or a 6 French sheath in the right femoral artery. And then now we have our arterial loop that we can use for infusion of supersaturated oxygen. So thank you very much.
Steve, do you need any special access in the femoral artery there, or is it just a plain old sheath that you use?
We just use a plain sheath. You know, we'll use the radial access that we have in the right, keep our guide, or switch the guide out to a diagnostic catheter, since we're going to keep it in place for an hour. And then I'll just use the femoral access. Any sheath does just fine.
And so you have to oversize the sheath. Yeah, you have to oversize the sheath a little bit compared to the French size of the catheter, so that you can withdraw blood. Is that how it works?
I would just keep the 6 French sheath, and 5 or 6 French sheath in the right femoral access, and then we keep our 6 French sheath in the radial access with the guide in place. So the system's pretty slick.
Gotcha. Okay, great. Thank you for that explanation and for the case. And now we'll turn to Dr. Andreas Schaefer to present a case and some also interesting images. Andreas?
Yeah, Dan, thank you very much for the kind introduction and the invitation to participate today. And I will give some interesting insights into our initial experiences with SSO2 in Germany. Now, it's also based on a case. The clinical case I will talk about is a 40-year-old female. She came with an acute anterior AMI, called the emergency medical team after a couple of hours of ongoing chest pain. So it was her first experience with coronary artery disease. And as you can see in the 12-channel ECG, she had anterior ST segment elevation and arrived at the hospital cath lab approximately half an hour after the appearance of the ambulance at her home. Now, in the initial cath, you can see that there is diffuse sclerosis in the right coronary, and there's a proximal occlusion of the LAD responsible for this large ST segment elevation infarction. Now, we did what we usually do. On the left, again, the image of the pre-PCI occlusion, then the virus that was passed, and in the end, three drug-eluting stents had been placed. And this is where we normally end our procedure, with the stents implanted in a good coronary flow, and would wait for what was ever going to happen. Now, in this case, we started the SSO2 therapy. Before that, I can show you the echo. The left one is coronary angiography in the cath lab when she presented. The other one is after the SSO2, and then the one 4 days after in the echo lab, done with original good improvement of the anterior and interventricular areas. Now, on the bottom line, you see the creatinine kinase levels of this patient, and from the type of occlusion and the territory that was occluded for several hours, we would usually assume several thousand units per liter of maximum creatinine kinase. Nevertheless, we got 710 approximately 14 hours after presentation to the cath lab. Now, what we are doing at our hospital is quite extensive imaging in patients with acute myocardial infarction several days after the acute procedure. So many of our patients get echo, get MRI, get special FARP imaging in PET-CT and spect. And what we can see here are two modalities for assessing the area at risk in the patient afterwards, after the actual infarction and revascularization have been done. On the left-hand side, very conventional, the edema that has been observed in the MRI in the different slides for the 4-chamber, the 2-chamber, and the left ventricular outflow tract imaging. And on the right-hand side, we see the FAP imaging, which is a very good option in PET-CT that our nuclear medicine department has developed. And it very nicely depicts the area that has been occluded during the acute infarction. And we are very well able to calculate the area at risk without injecting any dye or whatever tracer prior to the revascularization. And you can nicely see the large infarction of the interventricular septum of the apex and the apical lateral wall. Now, what we also do in these patients is the functional imaging, and I show you the functional data from the MRI, again made at day 4, nicely showing that there is a good wall motion at all areas of the infarcted area, with a good motion in the anterior wall specifically. Now, how to compare that to a patient not treated with supersaturated oxygen. On the bottom line, you see the patient that I just presented. On the top, you see a patient that presented and was not treated with SSO2. So the angio is pretty similar, and the MRI scans now with the weighing for the necrosis is quite different. As you can see in the upper image without supersaturated oxygen, very extensive necrosis in the interventricular septum and the apex. And in the patient treated with SSO2, you can see just a distinct necrosis at the apex and the lateral wall at the very end of the infarcted territory. When we look at other modes for perfusion, for example, we usually use the perfusion spect. And here you can see again the patient that I just presented on the top, the control patient that has not received SSO2. It's a large perfusion deficit in the anterior wall in the different imaging areas. And on the bottom, you can see the patient that I presented with a clinical scenario treated with SSO2. And you can see that there is almost no real perfusion deficit in the former infarcted area. Now, when we take this all together, we can see that this patient was rapidly admitted to the cath lab. The wire was crossed rapidly. 3 stents had to be implanted because of a slight dissection distal to the second stent. And then we had the angio after the last stent. At that time, we had already made the decision that this patient would be treated with SSO2. So the cartridge had been inserted, the system had been powered up, and we rapidly exchanged the 6F femoral sheet to the 7th French sheet to draw the blood and to administer the reperfusion catheter. And that was done also very quickly while we primed the system with blood from the sheet. The catheter was placed, and so within 4 minutes after the last angio following stent implantation, SSO2 therapy was started and was successfully completed over the full length of 60 minutes.
Thanks very much, Andreas. That was really, really informative. So now we've got some time for questions and discussion. Please enter any questions that you have in the Q&A box, and we'll try to address them. First, let me start off with Andreas while people are posting questions online. The images that you showed are really fascinating, and really thanks for sharing them. My first question for you is, can you tell us more about how many patients you've treated with SSO2 and if the findings that you've shown us are representative?
Yes, we actually started in the end of March this year, and we have treated 6 patients with SSO2 in the meantime. And the findings seem to be very consistent in this early series, in which we were able to perform this extensive imaging that we like to do in the large anterior MI patients anyway. There's a special interest in our imaging departments, and they developed this imaging, for example, the FAPI, which was actually derived from the cancer biology and gives us a very nice opportunity to determine the area at risk in a patient even several days after the actual infarct happened.
Yeah, so this FAPI imaging is, I take it, not standard. It's FAPI stands for fibroblast activating protein imaging. But you do this in all your patients with these large anterior MIs, I gather, along with these other investigations. And maybe I could ask the others, Richard and Steve, what type of imaging do you routinely do in your STEMI patients to follow their recovery? Do you do this extensive type of imaging?
Yeah, most of our patients just get echoes. We don't typically even do MRIs unless there's a reason or if there's a protocol, but echoes and follow-up, and the general cardiologist usually will handle that, but that's all we do.
Steve, same thing?
Yeah, we don't have FAPI. It sounds really fascinating. I wish we had it, but we don't really have that available. And we typically rely on echocardiography. It's a great way and an efficient way to follow patients longitudinally.
Yeah. Okay, great. So Richard, you talked about the need to improve STEMI outcomes, especially as it relates to reducing infarct size and developing heart failure down the line. Do you think there's general awareness of this problem and the concept of microvascular occlusion among your interventional colleagues? And do you think there's some reluctance around doing more for these patients at the time of the procedure beyond just opening the artery?
Yeah, without a doubt, that's a great question. I find surprising reluctance in this area, but it's mostly because the nature of the studies that were done, we're looking at a straightforward target of infarct size. And what I've discovered is that the clinicians have trouble getting their arms around that, even though you can show them study after study that shows that infarct size does matter. In the absence of the true clinical outcomes like heart failure or death at 30 days, there is reluctance about that. And I think that's something that we have to do a little better job educating our colleagues about it, but also designing better studies with endpoints that the folks in the community can really put their arms around. And the typical thing you hear is, oh, okay, big deal, the infarct size was smaller. And it doesn't sound like a lot, right? From roughly 25% to 19%, but that actually is a pretty big drop in infarct size. And it's actually comparable to what we got from lytics way back 25 years ago. That was about the same reduction in infarct size that we had for going from lytics to angioplasty. And that was enough to convince the world that we should be putting stents in or balloon angioplasty instead of lytics. So I think it's an education issue, and we just have to be smarter about how we present the data and also how we conduct our studies in the future.
Yeah, I mean, I take your point, but there's really good evidence, and you showed a lot of it, that infarct size certainly relates to development of heart failure, and infarct size certainly relates to mortality down the line. Steve, do you find the same with your colleagues? And what should we be doing to convince them to be more concerned about this issue?
Yeah, I think that, the utilization of SSO2 therapy is fairly well defined. Right now, we use it in patients with anterior infarctions, LED distribution STEMIs that are less than 6 hours in presentation. And so if someone has a perfectly normal left ventricle and it's an easy vessel to open, they've appeared very quickly, then I don't know if no one really thinks of doing this, but everyone else, I think it's becoming almost routine that if you're within 6 hours, if you meet the guidelines and you have any decrement in left ventricular function or any decrease in flow that isn't really, really easy to get rid of, we move straight to SSO2 therapy. And it's becoming more and more the standard of practice at our institution for STEMIs, for LED STEMIs.
Yeah, let me just ask a specific question about one of your comments there. And actually, in the case that you showed, there was low flow in the epicardial vessels even after the opening of the vessel by PCI. So do you look for low flow as a trigger for initiating SSO2? Because the clinical research shows that even if you have normal epicardial flow, you still can have significant amounts of microvascular obstruction and regions, especially on the periphery of the infarct, that are not getting perfused.
Yeah, so the things that I really look for, Dan, are I want to know what the LV function is, and I don't obviously do a great LV-gram, and I think that echocardiography is readily available to us, and we could see what the anterior wall is like even during a STEMI. But I do look to see how much I'm fighting with the LAD to get perfect flow. We still use thrombectomy periodically. We're very liberal about using drugs such as adenosine or nipride or calcium channel blockers in the artery to try to establish as much flow as possible. And now we have the added quiver in our added arrow in our quiver of using SSO2 therapy. So I think all of those have to be evaluated at the time of the procedure and choose the right therapies.
Yeah. Richard, back to you. A question. You showed impressive findings about recovery of LV function in your patients that you treated. How about the longer-term clinical follow-up? How are these patients doing clinically, and how are they doing in comparison to what you might have expected had they not received SSO2?
Yeah, that's a great question. The patients we did were over 5 years ago, and a lot of these patients come from other referring doctors. So unfortunately, we don't always get the follow-up we want, but out of our 5 patients that we treated at 5 years, we know that 3 of them are doing very, very well. So it's very anecdotal, small numbers, hard to tell, but everyone has the same experience with these anterior infarcts. They might look good for a while, but a good 20% of them, something happens down the road, and usually within 3 to 6 months, that they have issues with heart failure or repeat hospitalization. So that's a very important endpoint. It's something I'd really like to look at moving forward, to be absolutely sure that we're not just treating a number, that we're actually treating the patient. But I'm very confident that, just like Steve said, you see that big anterior wall on echo, irrespective of the flow. If you see a big anterior wall defect, they should get SSO2. And I would predict that we'll see, if the proper study is done, we'll probably see a 50% reduction in those MACE events at 6 months. I'm very, very confident of that from what I've seen.
Mm-hmm. Interesting. Let's talk a little bit more about logistics. Steve, what drove you actually to decide to use SSO2 therapy? I know that you're among the group of clinicians that are early adopters of new technologies. So was it your curiosity about the therapy or the clinical results? What drove you to initiate this in your hospital?
I think what drives us to utilize it is to try to improve the outcomes in anterior MIs. So there's nothing worse than doing a successful PCI and then the next day, you get the echo, the patient looks good, and you have an EF of 35 to 40%, and the echocardiographer says, oh, there might be a little bit of thrombus in the apex, and now you have to anticoagulate. So I kind of feel like if there's something better than I could do, I want to do it. So that's by far the #1 reason to move forward, is to try to do everything we can while in the cath lab to improve the outcome.
Andreas, how about you? What has driven you to adopt this? Is it the similar kind of feelings?
Yeah, similar things that it is frustrating if you arrive the next day on ICU or the coronary care unit and you see that the patient that was originally doing well deteriorated overnight, and you wonder what you have missed or what you could have done differently. And we looked into several of the other techniques and investigations going on, specifically in large anterior MIs. Remember that there are cooling trials, unloading trials going on with the same idea, but it was a bit frustrating for us to see that the other trials or methods required a delay of revascularization. And what was appealing about the SSO2 is that you can just perform rapidly the procedure and then can start with the specific intervention afterwards.
Yeah. So let's talk a little bit more logistics. Steve, if I can ask you, how have you integrated this into your workflow? How was the process of getting this therapy into your hospital and educating your staff and understanding about how this whole therapy is delivered and what you do during the administration of this therapy, which requires a 60-minute infusion? So can you talk a little bit about that, how that all kind of evolved, how seamless was that process? What kind of buy-in did you have to have from your staff and your colleagues?
So definitely there's an educational piece, and then TherOx and now ZOLL have been terrific about educating our staff, teaching them how to do this. Everyone understands what the time commitment may be and how to mitigate the time constraints, how to make your time more efficient during the whole process. But the company's been very, very helpful, educational for training the staff. There's also, like, we didn't remember how to do it immediately. After we did one case, there's a 1-800 number that walks you through this. If you're in the middle of the night and there's no one else around but you and a nurse and a tech, and it's worked relatively seamlessly. I think that, and then obviously as you do more cases, everybody becomes much more familiar, and it becomes kind of part of the whole protocol for anterior MIs.
And does your staff, are they motivated by the results that they see, that, you can see this dramatic improvements in ventricular function? Do you feed that information back to them to help motivate them?
Absolutely. I think more and more we are. The staff really wants to know how these patients are doing. As we do these more, as we do devices like Impella or other CPS, ECMO, et cetera, the staff really want to know, how have you done with these patients? So I think if we can achieve better outcome, keep giving them feedback, everybody's willing to do these extra procedures more commonly.
Andreas, has it been relatively straightforward for you for adoption?
Yes, it was very straightforward, and we were lucky to have 2 cases in the first week. So there was quite a retraining after the first one and applying it again. And then very nicely after we made the press release, we got requests from several TV stations to actually go back to the cath lab and to make a small movie. And we had to do this several times. And so we had to retrain the people, and we had to make all the setup. And they were actually seeing the movies from the TV stations with the individual patients and the follow-up of the patients a month later. And that was very, very helpful. And nowadays, if you hear there is an acute anterior MI, you come to the cath lab and the device is already placed in the cath lab. You do not have to ask for it. They actively ask you, do you want to use the device?
So in your practice, Andreas, Steve and Richard commented that, what you look for to initiate this is maybe some residual dysfunction on a ventriculogram or some low flow. What are the criteria that you use to initiate this therapy? Is it everyone that has an AMI, anterior infarct, ST elevation infarct that gets it? Or do you also look for those similar kinds of triggers?
We basically look for all the large anterior MIs at the moment, just for training, first of the cath lab nurses and second of the other investigators or interventional cardiologists. We put it on the daytime AMIs, and if it's a large MI and it's below 6 hours, we are going for it. And I think in the future it might be interesting if we have to weigh which patient should receive the therapy. We might have some enrichment criteria, or we have, this is another discussion in Germany, at least at the moment, a real trial to be conducted. So there will be clear criteria whom to include and whom not.
Is it being adopted yet in other centers in Germany?
2 other centers have started very recently, I think early in September and one late in August. Yeah.
That's encouraging. I guess one question that has come up is whether or not oxygen actually is toxic to the myocardium. We always hear about free radicals and reperfusion injury, et cetera. Do any of you have a comment about how to address that issue with that comment? I know that there's some preclinical data, but what's your feeling about oxygen being toxic to the myocardium?
I don't think that's an issue. I think we would have seen something by now, either in the preclinical models or in patients. And 1 hour is different from 2 or 3 days of high oxygen therapy. So yeah, I don't think it's an issue.
Yeah. Yeah, I think also there was preclinical data actually measuring myeloperoxidase, which is kind of an index of free radicals, oxygen-free radicals. And they actually showed that it was reduced during this reperfusion therapy, SSO2 therapy. And the reason for that is that a lot of the free radicals that accumulate in the myocardium are due to the stasis, that there's no flow. So if you restore flow, the flow washes away those, those free radicals. So I think that was a question that came in from the audience here. We have another question that's come in. How have you integrated this therapy into your practice, specifically to manage the 60 minutes of perfusion? Is there any special? What do you do during that 60 minutes?
In the beginning, we were quite curious, and you cannot do a parallel angiography or whatsoever. So we were really looking on the patient and clinically judging the patient. But once you do it 2 or 3 times, you see that these patients, they are absolutely stable. They are comfortable on the cath lab table. You can talk to them. And so in the beginning, it was half an hour of curiosity. Now it's really, I want to say, boring. You wait and there's nothing specially happening. So everyone is very happy that nothing is happening. And it's very well tolerated, and there's plenty of time to talk to patients, to address the history of the patient, comorbidities and whatsoever. I think this is also very helpful.
Yeah, I would agree with that. You know, obviously there's a lot of things to do following a case too. We don't leave the room, but you can get a lot of your charting done, some of your communications, et cetera, and as well as talk to the patient. So we don't leave the room or do some other procedure, but there's plenty of things to do, and it's amazing how fast it goes by.
Another question that's come in, very interesting. Has this therapy been considered to be used in AMI in patients who have shock? Obviously, those patients have even larger infarcts and maybe even more to gain. Richard, have you thought about this?
Oh, I think for years, ever since I saw this technology, almost over 20 years ago, I was intrigued with that. I think you just think of it as a spectrum of outcomes, and no one argues with the small infarcts. They do pretty darn good. The real big infarcts don't do as well, the shock patients, and the ones we're treating in these trials are in the middle. So, and also, if you remember in the MI-HOT1 trial, we included inferior infarcts in that, and the results were not as good because the effect was muted by the fact that you had mixing smaller infarcts with bigger infarcts. So it's yet another signal that it's just so intuitive to me that the bigger the infarct, the better they're going to do. And I think the delta that we'll see in the shock trial is going to be impressive. I really do, because this is really a physiologic alteration at the cellular level. And those patients have such bad clinical outcomes that we should be able to see a signal there that is going to be impressive. The bigger question I have is, and I'd ask Andreas and Steve this also, is what do you think about a big inferior infarct? I don't think there's anything special about the anterior circulation. If you had a very non-dominant LAD, which is possible, and a real dominant right coronary, would you use a right coronary infarct? Would you use this? I would. It's just muscle at risk, but I'd like to know what the other guys think about that.
It probably will work to prevent the microvascular obstruction, but as long as we use the the LV infarct size and compare infarct sizes between different patients, we've seen from all the other techniques that it was an effect limited to the large anterior MIs. Physiologically, I think it will make perfect sense, and there are also complications by a large infarct in the other territories. If we look at mitral valve dysfunction after large extensive circumflex infarcts, but we have to choose different parameters for outcome if we want to use it in other territories and not be fixed on the absolute measurement of LV function, because it will be more crucially be impacted by the LAD.
I totally agree with Richard. I do think that, you know, if it works for the LAD, it definitely should work for RV infarcts of large territory. You just can't tease it out of the data yet. But once that data becomes available, I mean, we do RV PELAs now. You know, we do other things to try to support large RV infarctions. Why not this?
There are studies that are being organized now, especially what's called the ISOSHOCK study is being organized, and will specifically investigate that question. And also, of course, now SSO2 is really only indicated right now, at least by the FDA labeling, for anterior infarcts, LAD administration. So, so Steve, before we kind of move to a summary of where we're going, since you seem to have a lot of success in integrating this into your practice and with your colleagues, what would you advise? How would you advise people if they're interested to get involved with SSO2 therapy for their patients?
Yeah, I think first of all, it's just trying to get the best outcomes for anterior distribution STEMIs. So if and it's pretty straightforward. Any patient who comes in less than 6 hours is from time of onset of chest pain, they're a candidate. And then it's up to the angiographer to assess how good is my result, how good is the left ventricular function, and then try to maximize the benefit for the patient. So how would I get involved? I would seek out the device if it's not already in your cath lab. If it's already in your cath lab, keep your eye on who those patients are that fit the criteria. And I think it's fairly simple and straightforward who would benefit from this at this moment in time. As our data accumulation gets larger and larger, hopefully we'll expand this out to other STEMI patient populations.
Yeah. Richard, do you have any final thoughts about this therapy? You've seen so much over your career and contributed so much. It would be really, I think, interesting to hear your perspective on this.
Well, I think it's breakthrough technology. I'm disappointed that it's not getting accepted as quickly as I would like. I would use it on every patient. First, we didn't talk about the earliest data, but there was a randomized trial way back in 2000 by Antonio Barbarelli in Milan, and it was really nicely done. Very simple study. Half the patients, about 40-something patients, half got SSO2 anterior infarcts and half didn't. And the ejection fraction curves just separated immediately and continued to separate. And the LD recovery was not just noticeable, it was striking. So that was my first look at this. And since then, I've studied it, I've looked at it, I've participated in the trials. I think it's breakthrough technology. I think it would be a shame that any patient with big anterior infarct, it didn't get it. It really should be first-line therapy. The company's made it easy, the technology's easy. I don't see any barriers to success. I think it's going to be a breakthrough.
Great. Andreas, any other comments that you might have in closing?
I think it's a very interesting time we are living in, and we are really looking forward to see this technique being used in more and more patients and in more and more hospitals.
Great. Thank you all for participating. I'd like to summarize kind of what we've heard today. If we could bring up the summary slide. We've heard that outcomes for STEMI have remained stagnant for quite a long time. Infarct size and microvascular obstruction are correlated with heart failure hospitalizations and death. We've known this for a very long time. SSO2 therapy improves microvascular flow and LV remodeling in anterior MI, and it reduces relative infarct size by 26%. That's following PCI for stemming. The TherOx device integrates easily into workflow without impacting door to balloon times, and experience from many people that are now using this therapy show good outcomes and good quality of life for patients who receive the therapy. Accordingly, this therapy is something that should be considered for STEMI patients. So this brings us to the end of today's live webinar. I hope that you found it informative and have met its educational objectives. I'd like to remind you that this program has been supported by ZOLL through Radcliffe Cardiology. Thank you very much for attending and look forward to further discussions with all of you. Thank you all for the excellent discussions.